Thank you very much, Dr. Mahipal sir and Gaurav, and pleasure to be a part of this conclave. A wonderful achievement from the iOS part. We talked about various, imaging systems. Introp OCT is also a new thing which we had for last 6, 7 years now. We've done a lot of work in various fields, right, from corneal surgeries to refractive surgery to lens surgeries. And I have no financial disclosure that I am employed in All India Institute of Medical Sciences, a premier institute of country, and work in the apex center of the country, Dr. RP Center for Ophthalmic Sciences. White cataract, we all know, does have a lot of challenge in terms of doing a good capsular access. And most of the time, in the intermittent cataract, extension of capsular access makes things very, very difficult for surgeon. Pre-op examination does help in these cases, CILTAM, which gives you an assessment of the cortex, the capsule, the bulge, the interlenticular pressure, and that can be compounded by anterior segment OCT. But the important thing would be it doesn't give you a morphological features on the table after you do initiation of your access in these cases. Therefore, intraoperative optical coherence tomography microscopes would give you those dynamicity which can happen during your surgery with these difficult situations, right from a subluxated posterior polar or white cataracts, and gives you opportunity to classify these cataracts and design your surgical technique according to the morphological feature you see in these cases. So this is our paper on classifying the white cataracts based on our intraop OCT pictures and the changes happening after you initiate the capsular access in these cases. So we have had a series of cases of white cataracts, and we have classified them in four categories, though we do have a spectrum between these types also. So classically, there are four types, and the type 1 we have classified, which is seen in a slightly older age group, where you have an OCT picture which is regularly arranged lamellar cortical fibers, minimal intralenticular clefts. You can see one here, but there are no clefts in the anterior part, and the uniform flattening of anterior capsule observed when you inject a viscoelastic anterior chamber. In such cases, there's a very little chance of raised interlenticular pressure as such causing a rexus extension. Therefore, rexus is simpler in these cases with a cohesive viscoelastic cover in these cases. Type 2 variety of white cataracts in, based on IOCT picture, which is seen in around younger age group, where we can see increased convexity of anterior capsule. You can see here. Then we have a continuous hyperreflective cortical band or sheet, which is going across the length of an entire lens. And in between, you have these clefts of fluid, which is beneath these hydrated cortical fibers. In such cases, as soon as you make a nick in the capsule, the entire hydrated cortical fiber bulges out and doesn't allow the clefts to get released, the fluid get released. And these are cases you can have a high chance of a rexus getting extension to periphery. If you see this video here, you have a clefts here and thick sheets. As soon as you make an initiation, the entire cortex bulges out like a hill or a mountain and causing pressure to the periphery of a capsule. There is a high chance that the capsule can go to periphery. In such cases, we make a small opening, keeping the viscoat or a dispersive viscoelastic in periphery. Once we remove the cortical hydration, you can see it's flattening and subsequent access becomes simpler. So these cases, because you have a thick sheet of a cortex, needle aspiration may not work in these cases. This is the type 3 of cases where you have convexity of anterior capsule, as well as you have a hydrated fibers, but the length is missing here. You have a broken hydrated fibers and clefts are also there. These are cases, as soon as you make a nick, there's a release of a fluid. So we understand these cases, the release of pressure decreases the intralenticular pressure. Needle aspiration would work in these cases. Similarly, we can make a small opening or wait for some time to get this milky turbid fluid to come out and release the pressure from the behind the capsule in these cases. If you see this video here, you can have a thick oily type of fluid coming out, and with a gentle pressure in the side port, you can release the pressure and flattening of entire anterior capsule, and you can complete the rexus and can assess your pressure and do a spiraling technique, get to a size where phaco can be easily done, and subsequently after completion, you can implant the IOL and you can redesign, refashion your capsular rexus size as per the requirement of these cases. So type 3 cases are simpler than the type 2 cases. So this is one case which is between type 2 and type 3. I was talking about spectrum. You do have a spectrum like this. That this is a case where you have a fluid also, you have a sheets also, you have a clefts also. Such cases with initiation, again, you may have to see what type of pattern you see after initiation. There, I don't see the hill type of pattern coming in these cases. So simply aspiration would do in these cases, and the phaco can be completed easily in such cases. So this is a type 4 variety of cases where you have a thick homogeneous fluid collection behind the anterior capsule, which is going towards a Morganian type. But here also you can have a raised pressure sometimes. Sometimes with the milky fluid coming out, the entire capsular bags becomes little loose, and nucleus can be freely rotating in these cases, and access become difficult. So you have to have a viscoelastic pressure right from inside the bag and outside the bag to complete access in these cases. In femtosecond laser also, as we discussed our posterior polar cataract, same thing can be assessed with wide cataracts also. And we can classify the wide cataract based on the OCT picture. You can see a homogeneous background behind the anterior capsule. You can see here with a little bit of cortical fiber hydration. So there is a chance of raised interlenticular pressure here. Also, you can see here, as soon as we apply the femtosecond laser, the fluid coming out in the breast, that indicates this patient did have despite having a type 4 type of wide cataract, did have a raised interlenticular pressure. So in such cases, after aspiration of fiber, you can see these are fibers which are still seen. So this was between type 3 and type 4 type of wide cataracts. So these varieties can be nicely assessed with intraop OCT and can give you the dynamicity which happens after injection of viscoelastic before initiation of a capsular exit, or after initiation of capsular exit, what happens and how to avoid these circumstances to decrease the complication happening in these cases. If I summarize, this was a spectrum of wide cataract in these cases. Type 1 is simpler, seen in around 80%, 18% of cases. Type 2, which is difficult, seen in less number of patients. Type 4 and type 3 are seen in a larger number of cases in these cases. So I can understand type 2, if you see those type of cases, you have a slightly higher chance of rexus getting extension to periphery unless you take appropriate measures during your initiation of capsular rexus in these cases. Type 3, type 4, needle aspiration of cortex or exchange with viscoelastic or doing a small capsulotomy will help in these cases. So all wide cataracts are not similar. You have to understand the clinical picture in the pre-op examination with slit lamp or anti-segment OCT. Intraop OCT does give you a lot of help. And this particular video, we have won the Best of Show award in American Academy in 2018. Thank you for your kind listening.